Thank you so much, and thank you for inviting me today. So it's the bright green button, is that correct? Anyway, I apologize. I have a little bit of a cold, so hopefully you all can hear me. I do appreciate that many of the speakers before me have in fact presented Oregon data, so I'll present a little of it. But this session is really to talk about what the data are and what the data are not. And so I want to be the first person to kind of recognize what the role is of the government and what the role is of outside researchers, et cetera. I'll start off with a disclaimer. People used this mostly yesterday in their sessions, but I'm an epidemiologist, and so that means that I look at patterns of disease and conditions in the population and things like smoking and obesity epidemic, et cetera. And it also means I have a particular way of approaching a problem. And I'm not an end-of-life care researcher, and so there are a lot of things that people have brought up around the ethics that the data themselves can't answer. They need to be used as kind of a backdrop for a lot of the discussions that have been happening. And so I believe strongly, and I have since the beginning, that the state of Oregon, citizens voted for this, but the state government, in a sense, is neutral about the pros and cons. This has been passed, and we believe that the data are really important to continue the discussion about it. So I'm also going to say that I will talk throughout this talk, I will use the words death with dignity. It was talked about yesterday that there's been a little controversy on how to refer to this, and that controversy actually happened in Oregon as well a number of years ago. And so we elected to just use the name of the law that was passed in Oregon as being as straightforward or neutral, and if people want us to use other language, then they should change the name of the law itself. Okay, green button did not change. It's a green, oh, the giant green arrow. The obvious green arrow. I thought it was the green button. Sorry. All right, so again, people have talked about this before. It passed twice in Oregon, and it was first in '94 and then again in '97, and it was held up by court injunction during that period of time. I will state, though, that this is a permissive law. People often call us and say, well, I want to sign up for your program or give us data. There is no program. So the law itself really allows qualified patients to request a prescription and for providers to provide those data at all. I was really appreciative of the very first session this morning that talks about what has to happen in terms of policies, procedures, et cetera. As a governmental official, we look at the law. We then write administrative rules related to the law, and that is what we collect data on. So again, I do believe that there's larger context, and we want to provide that data, but I want to be clear that that's the context as a governmental official. So again, the law outlines a number of the requirements for patients that they have to follow up to the point a prescription is written. The law does not address everything that happens prior to that point. Again, there's these very clear qualifications that need to be followed, and it does not address what needs to happen after the prescription is written. So there are a lot of questions, again, about those two sides of it, but I want to be clear that, again, in Oregon and a number of states that have this very specific statute, it really is those qualifications to the time the prescription is written. Now, this was a citizens' initiative, and it required the Oregon Health Authority to monitor compliance and issue an annual report. So it did not state that we should be collecting all data on all aspects of end-of-life care, et cetera. And again, I'll talk a little bit later about some of the gaps in data collection. So I'm going to talk very briefly about statutory requirements and then our data collection process that we put in place. Including the monetary reporting system that I just alluded to, the compliance part. And while I say compliance, I'm not a regulator either. Again, I'm an epidemiologist, public health physician. So regulation that some people are looking for really is done outside the realm of the public health authority, and I'll talk about that a little bit later. Something about the context, and again, that's really where we're going to address a lot of the gaps in the data. I'll briefly present the 20-year experience. You've seen some of that already. And then finally end with some of the considerations around the data. Now, I think that these three things often get confabulated. People often say, well, there isn't enough data on, the state of Oregon doesn't collect this or that, and it's because they're really distinguishing between our role in collecting data or monitoring compliance and issuing an annual report is different than what we know about the broader context. Okay. So again, very quickly on this one, I think it's similar with other states. This is spelled out in the statute itself. The reason I put up these slides up here is because this is what really led us to our initial reporting system, was looking at what was in the law and how were we going to monitor them. So again, there's a process with the number of requests, the 2 physicians. Again, people have spoken about this at length already. So when we looked at what our role was, again, as an epidemiologist, here's a new law, and I think, well, how do we approach this? And so, like many things, we actually got together an external group. There was a task force to improve care of terminally ill Oregonians. It was actually the Oregon Health Sciences University that put it into place after the law had first passed in 1994. Put that in place to actually look at things like hospice coverage for the state and guidance for clinicians about what should happen if a patient gives you that request, et cetera. So this was a good sounding board for how should we set up our monitoring surveillance system. And there are really 3 parts to our current surveillance system. The first one is the very specific that I would say is written in statute. At the time a prescription is written, people need to fill out one of our forms and send that to us. That is what's required by the statute and by our administrative rule. It happens, again, after the prescription is written, so not every conversation, again, was talked yesterday, what's the entire population and who might have fallen out from this because they didn't have cognitive abilities. We don't collect data on every conversation, and I don't think anybody wants the government to be collecting data on every conversation that patients have with their physician. We also knew, though, and we have a separate role, and we collect birth and death certificate data. We analyze those data. That's routine, part of our Center for Health Statistics. And so we can match, because the next question, even though it's not in the law, most people want to know, well, who actually died by these medications? So we have a process for that. The third piece is that even when you match on a death certificate, you don't necessarily know whether the patient took the medication or not. And so we have physicians fill out what we call a follow-up form that has a number of the data that folks are interested in. So that is the process overarching. So again, for the mandatory reporting pieces, we have that in our administrative rule, and whether they met specific requirements. And then based on that, that's when we issue noncompliance with any of the steps to the licensing board. And I'll talk in a minute about the number of people we've actually referred. But we decided again that, let's say somebody, and Pete Reagan mentioned this yesterday, 15 days is hard, what about 14 days? Well, I'm not going to say 14 days is enough. I don't want, what about 13 days or 12? So I said any issue that I don't see, full compliance, I will report it to the medical board. So again, I'm not in this to make those value judgments. That's something that needed to be done by elsewhere. And then we also do get data from the death certificates around some of the demographics, education, underlying illness. And I did hear the discussion yesterday that death certificates aren't necessarily the best place to get demographics on race, ethnicity, et cetera. But again, that's a standard. It's used around the country, so I certainly know the problems with death certificate and those data. We'd love better data. The question is, at what point and where and how do you collect all those data that people want to have? So anyway, we are, at least at this point, we get those from our death certificate. So again, we were also aware that people were concerned about some of these issues for policy and research. So we get that from the post-death follow-up forms, how many people die from the medications, and some of the reasons. It's been alluded to here today. And are there concerns about more existential reasons, or are there things like end-of-life care access, pain control, financial concerns, et cetera? Now, again, a number of people have been interested in things like how religious, what's your political affiliation. With that task force, we knew that as state government, we weren't really in a position to ask a lot about religious and those kinds of things. So we really wanted to ask things that the state might have a role in addressing, like pain control. If people didn't have access to adequate pain control, that's something we could be involved with. And the same with financial concerns when it came to health insurance, et cetera. So I'll briefly talk about Oregon data. Again, some of this has been alluded to earlier. Over the past 20 years, there have been 1,967 prescriptions written. 1,275 people have taken those medications to hasten their deaths for a 65%. And again, it was talked about already, so that's about 2/3 have taken them and 1/3 have not taken their medications and have died of underlying causes. We have 35,000 deaths in Oregon, so overall it's 0.2% of Oregon decedents are dying using this. So the distribution, this is just the number and the age categories by age, and the median age is 72. And you can see there are some younger people with terminal illness, and then it drops off with age. As an epidemiologist, though, we're also interested in looking at the rates. So you're much more likely to die when you're older, and you're much more likely to get one of these underlying diseases. So we compared participants, or people, I should say, the cohort, who have certain underlying diseases, and we compared the age distribution. And what you find is that the younger population is more likely to participate than older population. That's the rate of people dying of similar deaths. So again, there might be a number of reasons for this, including attitudinal, and we'd also talked about potential cognitive impairment. So that might be something that declines with age. By education level, again, on the left column is just the raw percent, but when we compare the people with the same underlying diseases, you can see that those that have a bachelor's degree and or a graduate degree are far more likely, they have much, much higher rates than those with only a high school degree or less. Underlying causes of death, again, most people die by have cancer as their underlying cause, and there's a smattering of others. People who have ALS by far have the highest rate of participation. So again, looking at the population of people with ALS, they're far more likely to participate. Okay, and physician participation since 2000, so again, that's when we started maintaining ongoing data. There have been 374 physicians who wrote the prescriptions. The range of prescriptions have been from 1 to 85, so we do have some people who write a number of these. And again, that is 0.6% of licensed Oregon physicians, so it's a small percentage of physicians who've participated. As was alluded to already, the referred for psych evaluation has been low, 5%, and it is dropping. I think last year it was 3.5%. Healthcare provider being present at the time of death has also declined. Location of death, by far the most common is home, followed by assisted living. 7 people regained consciousness. So we think that's important because these medications do not work uniformly. So end-of-life concerns, I see my time is almost out, and I haven't even gotten to what the main questions are. So I'll skip through these. These are all in the annual report that we just issued, so people have access. But again, this has been talked about already. So some of the data collection issues, and I know others are going to speak at length, I really do think that understanding the purpose of data, what it's used for and why, is important. Is it for monitoring? Is it for compliance? Or is it for research, for us understanding more? How it's collected. We get our required reports, we get our death certificates. We also can do special studies, but again, that is not the same as an ongoing data, and we are not, I'm not an academic researcher. The source of information is secondary for us. We get it from providers and families. The patients themselves, again, that is outside the scope of what we do in Oregon, but I clearly see that that's an important source of data. And I think it's important for us to balance and think about balancing the confidentiality, the rights of patients, this is, they're dying, this is at the very end of life, with the need that society has for understanding what's going on and what's happening with those data. So again, there's a tension here between transparency, regulatory, as well as the confidentiality. A number of the discussions have also been talking about what is not in the Death with Dignity. People want to know a lot more about what were the reasons for request denial. What about those psychological autopsies of patients afterwards? Why were they making this? What's the process after the prescription is written until death? What's the decision making? How do people decide when to take the medication or whether not to take the medication? What are those? And at the time of death, again, some people want there to be a whole team around and others really want it to be very private. And who can report the complications that are occurring? We now collect those only from licensed healthcare providers present rather than volunteers, because we think maybe volunteers for different organizations, while it's great they're there to support the family, but they might have a vested interest in making things look like they're going better than they otherwise might be. And there is no required patient follow-up, which means that some physicians do not know whether their patients took the medication or not. Physician retires, there's nothing to say. You have to keep following the patient. So this is my last slide. Thinking about improvements for data collection, I think clarifying the roles, what government does around monitoring and compliance. We do not get any funding for data collection. Now, as a government person, I'm not here to tell you need to increase our budget over things, but really our money comes from what we collect as part of vital records. So this is very limited, and were we to need others who've done research, get research grants to investigate this kind of thing. I do think there's a role also of us doing the monitoring and compliance with trying to get additional data. So we really need to think about who's in the best role to collect those data. And then the role of academia and researchers. What are the differences? Again, it's been alluded to a lot between the socioeconomic status of patients who participate, race. Do people have adequate end-of-life care who are making this choice, or are people making this choice because they don't? And I think it's important to share a range of experiences, shared decision-making, and how this also fits into the doctor-patient relationship. So all of those things are very important. So thank you, and I apologize for going a little over time.